Explosions are the primary cause of combat wounds. Most of these explosions are caused by IEDs, or improvised explosive devices. The soldier's personal protective equipment plays an important part in the pattern of injuries. The head and trunk are well shielded from fragments, but the limbs are poorly protected. Lastly, the PPE does not provide blast wave protection. After an explosion, risks of an additional accident must always be considered. Collapse of surrounding structures, a second explosive device aimed at responders. The primary injuries are due to the blast. They affect the persons closest to the epicenter. They are related to overpressurization shock wave. The Friedlander waveform describes overpressurization outdoors. Gas-filled organs are most sensitive to the wave: eardrum, lungs, stomach, intestines. The deck slap is a special type of blast wound. The legs and feet are injured when the shock wave hits the vehicle floor from underneath. Secondary injuries are due to fragments. An explosion throws fragments great distances. As a result, outdoors, although the blast dissipates quickly, the overwhelming majority of casualties will be injured by fragments. Fragment ballistics after an explosion are unpredictable. Fragment wounds can cause mere flesh wounds or rail-penetrating trauma injuries. Tertiary injuries are those caused when victims are thrown by the blast wind. They are usually closed fractures. Quaternary injuries are burns. The surroundings play a key role in explosion injuries. Outdoors, the shock wave dissipates rapidly, but it throws debris a long way. Indoors, the shock wave reverberates against the structure walls, causing increased blast injuries. Indoors, the collapse of structures, like a building, is a significant cause of mortality. Controversially, a wall of street corner may provide protection. Triage is the key to managing explosion victims. An explosion causes multiple casualties. They are multiple in number. Everyone can be injured by an explosion, unlike gunfire, and must therefore be examined. They are multiple in number on each victim. Several types of injury on several parts of the body may occur. There are multiple clinical pictures from the minor injury, flesh wounds, or acute acoustic trauma to the seriously wounded casualty. The otoscope is useless during triage. The eardrum is the most sensitive organ, but it does not indicate whether deep blast injury is present. The otoscope is useful for examination but not triage. Due to the complexity of post-explosion clinical pictures, the whole body scan is the radiological examination of choice. There is no medication specific to explosions. The adage, "treat the wound, not the weapon," is also true of explosions. Damage control surgery guidelines are ideally adapted to severely wounded patients. A pulmonary blast wave injury can worsen over time, like a pulmonary contusion. It may aggravate hypoxia and go as far as acute respiratory distress syndrome. The clinical picture from abdominal blast wave injury may emerge only later with a secondary perforation. In the long term, brain blast wave injury may be linked to dementia or post-traumatic stress disorder. Wounds for fragmentation. Treatment must not endanger the patient more than the bomb. Fragments are removed selectively. Remove the largest or most dangerous fragments close to a major blood vessel or nerve. There is significant risk of secondary soft tissue infection. MRI exams are counterindicated for life.